Hello, and thank you for joining the Kampala Initiative PPP Working Group and STOPAIDS for our webinar today to launch the Civil Society Principles for ODA-funded private sector engagement in global health. My name is James Cole, and I am the Maternity Cover Advocacy Manager working at STOPAIDS based in the UK. I'm really pleased to see so many of you joining the meeting this afternoon. We'll begin with a short presentation outlining the principles, and then we will hear from a brilliant lineup of speakers, which include Denis Bukenya from the People's Health Movement Uganda and the Kampala Initiative, and Marriott, Health Policy Manager at Oxfam, Dr. Mohga Kamal-Yanni, and finally, John Fairhurst, Head of Private Sector Engagement for the Global Fund to fight AIDS, TB, and malaria. But first, a few words on the principles themselves and why they came about. As I'm sure colleagues are very aware, from PPPs to biomedical research and development investments, over the past years, there's been a substantial increase in the amount of official development assistance being channeled to the private sector, looking to support the delivery of global health development goals. Whilst there are indeed examples of ODA-funded private sector engagement that have advanced global health outcomes, civil society and communities have identified several risks and challenges associated with this broader agenda. As we'll be discussing later within the case studies, this includes the lack of safeguards on the use of public resources, insufficient focus on the rights of the most marginalized, insufficient focus on people-centered approaches, and often a more skewed focus on more lucrative type of health investments, but sometimes can also increase health inequalities as well. And as colleagues will be discussing in this webinar today, there's often a growing body of evidence that suggests that the increased engagement of the private sector in global health without having clear guiding principles and binding regulations focused on increasing access and quality of services for the most poorest can lead to actions that do more harm than good. So this could be undermining the public health systems and also negatively impacting the most marginalized and most vulnerable populations. So the 6 different principles for ODA-funded private sector engagement in global health set out on the screen are not attempting to address all of the ways that the private sector operates in healthcare, but rather considering when official development assistance aid is being used for for-profit private services, the role of the private sector. And it looks specifically at considerations on how to advance the UHC agenda as well. So these principles we'll be coming to in each in turn, look to and have recommendations for specific areas of concern identified by civil society, where private sector investments and interventions pose significant risks. And we outline several different considerations for donors and other key global health actors to inform their strategies for engaging the private sector to support the delivery of global health goals. And as mentioned, each principle includes a recommendation for donors and global health actors. So I'd like now to go through each principle in turn. So principle number 1 highlights the needs for how ODA funding to the private sector mustn't undermine public health care provision. We feel this is essential as evidence shows us that in countries that have made significant progress towards achieving UHC, they've moved to a health system that relies predominantly on public funding from compulsory funding sources and effectively pooling resources for redistribution. Whereas we've seen private health expenditure being negatively correlated to health outcomes and undermines public health provision by often diverting scarce resources. So there's, of course, more information in the paper, But the key recommendation that we're putting forward for this principle is the need for donors and other global health actors to prioritize using ODA to support governments in low and middle income countries to expand publicly provided healthcare in achieving UHC that is accessible to all. Principle number 2 highlights the needs how for the funding must be driven by social accountability for health rather than commercial interests. We put this in to respond to the strong evidence coming out that demonstrates that too often that ODA has been invested into private healthcare has had a highly questionable development impact and doesn't necessarily expand access to those who need it, and in many cases can exacerbate inequalities. This will be expanded on further in the presentations you hear on shortly from both Denis and Anna. So we feel ODA must not be used to promote any form of private sector engagement that excludes those unable to pay for the services, and commercial interests must never be put above ensuring equitable access. We feel it's essential that all ODA funded projects must be able to demonstrate they do not exclude patients due to financial barriers. So there's many recommendations you could put forward for this principle indeed, but what we like to recommend stakeholders to consider is to stop investing in the expansion of private for-profit healthcare facilities and services where profit can be prioritized over equitable access. So the vision instead, and what can be tangibly done, is to see donors and global health actors dedicate resources to building public goods and capacity in national and global context, with a priority for strengthening public services for health. To move on to principle number 3, this looks to argue the importance of how the funding must have a demonstrable public health impact, be evidence-based, and adhere to the principles of equitable access to services. It shouldn't be needed to be said, but obviously ODA-funded private sector engagement investment in global health must meet the same standards as all other ODA-funded initiatives and developing cooperation modalities. To put simply, this must mean these types of private sector partnerships must do more than do no harm. They must do good, and they must advance human rights and access to care. If we don't achieve this, we risk seeing ODA being used unnecessarily to subsidize the private sector. So taking this principle forward, we ideally would like to see donors to stop investing in private health initiatives and services that aren't able to clearly evidence how and why they are best placed to contribute positively to global health goals. And looking specifically at the case of PDPs and research that will be expanded on further within Mohga's intervention, we think it's imperative that affordability and access are explicit objectives within PDPs. Moving quickly on to principle number 4, this highlights the need for strong transparency and accountability mechanisms in line with the principle of aid effectiveness. So we obviously think it's important and vital that ODA public funding and donors have a responsibility, both to the taxpayers and the communities that they seek to support, to demonstrate the impact of the public funding and publish the details of that impact. Often when the private sector is engaged in a development initiative, much of the agreement of their involvement is not published actually, citing reasons around commercial confidentiality often. And there's numerous examples of how PPP contracts are often locked away from public scrutiny and democratic accountability, despite the huge physical implications for the nations entering into these partnerships often. So as we'll be discussing shortly within Denis' presentation, looking specifically at PPPs, we want to see donors to stop investing in and partnering with private actors when there are no clear transparency and public accountability mechanisms in place. And secondly, we would like to see civil society and communities being meaningfully involved and having real power in governance structures. So I'm pleased that John Fairhurst from the Global Fund is joining us today. So obviously the Global Fund is one of the more advanced multilateral organizations that has a meaningful role within the governance for both civil society and communities. And it'd be good to discuss that further in the meeting if we do have time as well. So principle number 5 is highlighting the need for these investments to support and promote human rights and workers' rights. So we think it's essential that any of these ODA investments advance the right to the high sustainable standard of physical and mental health. And this includes the links to ensuring universal access to high quality healthcare services without discrimination. So to take this forward, a key action that DFIs could advance this on is by establishing clear engagement, consultation, and complaint processes, ensuring that the public and affected communities are aware and have a say in any DFI and IFI funding for particular institutions. And secondly, we think it's vital that donors build in a rights-based approach for any agreement with the private sector, which will help ensure that interventions do not breach human rights, including the right to equity, privacy, dignity, and finally, the right to live free from stigma and discrimination. So the final principle I'd like to highlight before going into the case study presentations is the needs for ODA funded private sector engagement in global health to not be used to promote private sector investment in health in countries where there is not effective regulation of the private sector. We put this in as we've been quite a few examples now of how aid has been used to promote this in countries where there hasn't been effective regulation of the private sector. And this creates several different challenges within these unregulated contexts. So we could see financial incentives being prioritized over public health. This could lead to a skewed focus on more profitable services, over-servicing, overcharging of care, as well as over-gathering of data and poor data management as well. We therefore think it's important that ODA is not used to promote or encourage a greater role for for-profit actors in countries where there is very limited regulation of the private sector, particularly so in fragile states as well. On the reverse side, there's very clear roles that donors can take to strengthen the capacity of governments to regulate the private sector. And in addition, we think there's a role for donors to identify and support governments to remedy any weaknesses in the governance or the regulation of the private sector or the services that they indeed seek to provide, especially where there are the potential risks to human rights. So those are the 6 different principles. I will turn back to the first page that outlines them all here. But to consider how they are or are not being implemented in practice within the current different modalities of private sector engagement in global health, I'm delighted now to turn to the panel discussion form of the meeting, where we will hear short presentations on different perspectives with a consideration of the 6 different principles as well. And if anyone had any questions or interventions, please do make a note of that within the Q&A function, or send myself and the STOPAIDS team an email, and we'd be pleased to respond as well. And just wanted to close my segment by thanking the different civil society networks that have been involved in supporting the development and the drafting of these principles. If your own organization would be like to endorse the principles and be listed your logo on the paper itself, I'll be pleased if you would be happy to consider filling out your details within the linked Google form to this webinar. Then we'll be pleased to add your organization support on, and please do share also with your civil society and community networks that you may be part of. But yeah, that's all from me now. So I'm now delighted to hand over to Denis Bukenya, joining us today from the People's Health Movement in Uganda and the Kampala Initiative, to give some reflections on the principles and particularly looking at the role of PPPs. Over to you, Denis.
Okay. So the next slide, please. The next slide, please. So my discussion is going to be a brief one, and I'm just going to look at how the principles could be applied to help realize the right to health. And I'll begin with the issue of looking at the counter the narrative. What do I really mean by us trying to counter the narrative? In some way, in some countries like Uganda, we've had the challenge that popularizing funding of the private sector to engage with the public sector has been a challenge, and they have given it all sorts of narratives. And in fact, at the end of the day, we have realized that the citizens have lost resources in terms of money misappropriated in the face of trying to create infrastructure that will improve health. So it is, and all this has been done in a way of trying to popularize an alternative narrative, or trying to popularize the PPPs. So I think it is incumbent upon us to use the principles, one, to popularize an alternative narrative or model for PPPs. That is to make them centered in such a way that they enhance access to critical services. And how do we position ourselves to better do this? One, we need to look at research. I think with the few people in philanthropy who can do research, or those who can fund research that can give us evidence, or the evidence-based kind of informed policy in countries, and to also be able to work with the evidence so that it can document the processes and the way forward. So that would be a critical issue when we are trying to make sure that the funding of the private sector to commence work on the engagement of the when the private sector is funded to do work for the public sector, that is important. Then again, when we get this evidence, some of the evidence we have that probably is not in the right positions or the right place, or is on the other side of the coin, we should use the media to really put it out there, so that we can either get a response from the global health governors, or we kind of tell the truth to what it is, or truth to power. And then again, we need to map out actors, that is from both sides of the narrative. And this will help us to better know who to engage in the event we feel that the right to health or health is being affected. Yeah, and this will create stronger alliances and build more cases for us to have an evidence-based, a wider evidence-based of scope. So again, you realize that the private sector really has capacity, and it is difficult for us to bring out the voices or dissenting voices where we think that there has been a bit of impairment on the right to health. So the issue of building capacity of CSOs, mostly for other actors who are within the engagement of this sort of advocacy, is also an important issue that we also need to pay attention to. And I think with the principles that should be properly taken care of. And then building a concrete group of people who are conscious of the shortcomings of PPPs, like the Kampala Initiative platform, and also looking at the technical working group of the PPPs and the work it's doing. And then also we have the issue of having to track other emerging distorting practices of aid and trade. Next slide, please. Yeah, so from a core group, again, that is the task group of the Kampala Initiative, that is the PPPs again. Such groups, people need to join them so that they all add their technical know-how, that it can again advance more enhancement of the right to health. Then again, identifying the capacity gaps, we need to look into ourselves who are doing a bit of advocacy around the issues of PPPs that are affecting the right to health, so that in a way we can find a way of covering up our gaps or the capacity gaps that exist within us. Then again, mapping of actors, as we have said, is an important issue. And then as we do this, we need to kind of document and know who is doing what so that we can support each other in one way or another. Then the other issue should be identify and engage other like-minded actors beyond the Kampala Initiative. We have groups, so many groups that at least I have been part of, the People's Health Movement. We have ISA, who are, for instance, having a case in Uganda against the PPP, a given PPP that has really caused a lot of financial loss to the country. Then we also have the consortium against commercialization of the health sector, and many others. So this is to be both immediate, and then also it can work for us in the long run. Then again, we need to have commitment amongst the participating people from this webinar, kind of to commit through the launch of this. We hope that the launch of these principles should have many other people committing to keeping a keen eye on the emergency of funding for the private sector to engage with the public sector. And then again, we need to look at the need to sensitize the masses about PPP project challenges. Most of these public-private partnerships are dressed up in gold. And at the end of the day, the process of them hurting the health systems instead of strengthening them, in fact, weakening them, is a slow but gradual process. And by the time anyone can see that the systems have been hurt, it is probably too late. And one of these best example that I can give from my side is the International Specialized Hospital, VOA, and then again, Queen Mamohato Memorial Hospital, Maseru, Lesotho, where we have what I would call PPP sagas. Next slide, please. Yeah, so again, we are looking at the risks in utilizing the principles in Africa. I will hinge most of my arguments on the Lubowa Hospital, that is a specialized hospital that we saw Uganda lose taxpayers' money worth 379 I think something like 79 billion US dollars. And for a small economy like Uganda, where a specialized hospital of what was mimicked in the artistic impression that was shared with the masses, at least cost 25 million. But when you talk about 379 billion US dollars, that could actually upgrade our entire health system into something that could attract medical tourism in Uganda. But exactly what happened, just showing the risk of utilizing these principles in Africa. The activism here needed to get responsible parties to listen, maybe to if we activists come up to talk about challenges like the Ruboa hospital issue, the government immediately would brand us, or we stand the risk of being branded sabotage of development of the development agenda in Uganda. Looking at the parliamentarians when they were faced with having to block the release of this, or guaranteeing that money to be shared with the guaranteeing that money to be given to the so-called investor, the parliamentarians denied access to where, when they tried to block the money, many of them were left out of the house. And then when they tried to monitor or do their work in supervising the money they had released, the parliamentarians, you can imagine, were locked out of the Goa hospital. And I think they tried to go to this site on the 8th of August in 2019. And the reason that the people who were blocking them gave was that they did not inform them there were issues of safety. But up to date, and I think that is like 3 years later, when you go to that place, now nobody stops you, but you find there's only a foundation and nobody can explain what happened to the money. Then again, another risk we may have to, that I wanted to bring to your attention, is the lack of transparency in these negotiations of these PPPs. So many a time, we think that it is deliberate to keep it from the citizens. So by the time you find out, it is in rumors, and many a time the politicians will deny this. The truth is, we lose a lot of money in some of these arrangements. So look at the ongoing issue at the Goa hospital. This one serves as a striking example of why opening contracting, there should be open contracting, especially this to reduce the corruption risk. Then again, the need for there is a need for an opportunity to open evaluation of these bids. If the money that was guaranteed for the building of that specialized hospital as a public-private partnership went through the right procedure and there was open bidding, then probably would have had better people better handling this money and giving us a better product, and us not being victims of corruption or failed projects. Next slide, please. Next slide, please. Yeah, so again, at the contracting stage, the government will easily hold the company if the contracting stage is done properly, or if the PPPs are fairly given to people who are competent. The government can easily institute suits against these people if the project is failed by any issue. But in these circumstances, now the suits are coming up against the government, and you find that because of these suits against the government, then the projects themselves take longer to take off, and the longer they take to take off, the more money they will attract in terms of penalties. Then again, approvals of public-private partnerships not to be marred with limited participation of the citizens. It is, I think, we owe the citizens a duty of care to have them participate extremely in what they are going to pay for at the end of the day with their taxes paid. So I think it would be fair to say that there should be a degree of citizen participation. Another issue is the governments and donors should at all times prioritize public health sector, as we have seen in the principles. So investing in there should be investment in a quality and equitable public health system, and then it should also come in as priority. And that is both by the government and the donor. Public health system is often the first point of call for the poor and the vulnerable. Next slide, please. Over time, we have noted that lack of participation in formulating PPP contracts and the fact that they may not be cost effective. Here we call for the official development assistance to tread cautiously, unless if they represent an invisible hand that stands to benefit from these inefficiencies. Next slide, please. Yeah, so I want to say that having been part of the process of these principles, I think they have been engraved in stone, and it is something that we can use as a tool to do a bit of advocacy, and we hope for the best in strengthening health systems around the globe. I thank you all for listening to me. Over to you, Paul.
Thank you very, very much, Denis, for the really wide-ranging and important presentation there, and really pleased that you're giving kind of tangible examples of the work being done and the brilliant work of the Kampala Initiative and partners, and the relevance of the principles as well. I'm delighted now to hand over to our next speaker, Anna Marriott, who is joining us from Oxfam today. And so I'll give you the floor, Anna.
Thank you, James. Can you hear me well?
We can, thank you.
Great. So unfortunately, I can't turn on my video, but hopefully you can hear me clearly. So just to start by saying thank you for inviting me to this webinar today, and it's a real privilege to get to listen to the other speakers. And also just to say that Oxfam has been actively challenging the privatization, commercialization, and increasingly, more recently, the financialization of healthcare in low and middle income countries for a number of decades now, actually. And part of this work has focused on access to medicines. The other part we have focused on is on healthcare financing and delivery. And it's that part that I'll speak to today. And in the last 15 years, we've tracked this shift in narrative in favor of privatization and a greater role for the private sector, away from what could be described as more simplistic arguments, simply cut government healthcare and free up the private sector to flourish in its place, towards one that uses this very same small government healthcare sector created by that intentional economic doctrine to justify the increasing use of scarce public resources, including ODA, to directly finance the private healthcare sector. And as I say, using ODA and other sources of development finance. And the World Bank, and especially the IFC, which is the private sector investment arm of the bank, has been at the forefront of this new narrative. But so too have actors like the Bill and Melinda Gates Foundation, global public-private partnerships in health, as well as bilateral donors, and especially their development finance institutions. And our work has tracked some of the technical advice provided by the likes of the IFC on health PPPs in countries like Lesotho, as Denis mentioned, but also in the promotion of public health insurance funds that have sought to incorporate an increasing role for private healthcare providers. But we've also tracked the investments in healthcare by the IFC, finding that the vast majority of their investments in Africa, for example, were going to high-end individual private hospitals or corporate hospital chains out of reach for those on ordinary, let alone low incomes. And over the last few years, we've been mapping the spending of 4 European development finance institutions, that of the UK, France, Germany, and the European Union. We've been tracking their spending on for-profit private healthcare companies. Sorry, private health companies, but with specific attention to the private healthcare providers, so the hospitals and clinics. And we'll be publishing our detailed research next year, but here I'd like to reflect on some of our broad findings on the IFC as well as the European DFIs in relation to the principles that are being launched today. So firstly, the first principle of not undermining public healthcare provision. And at the heart of the rhetoric justifying an ever greater public investments in private healthcare is weak and under-resourced public provision. And we could spend a whole session challenging that rhetoric. But at the very least, DFIs the development finance institutions must ensure that their spending does not further undermine already weak public provision. In our research, we found nothing to reassure. And just a couple of examples here. We found many problems, from glaringly obvious issues like where do the health workers come from to staff these private facilities in a context of desperate health worker shortages in public facilities. Other examples include evidence that DFI supported companies are exploiting and abusing publicly funded national health insurance schemes, draining public funds that could be being used for public provision by cherry picking more profitable procedures to treat, while refusing to treat those that are less profitable, and leaving those patients to seek services in the public sector. In India, where there is a very high concentration of DFI health investments, we also see multiple hospitals in receipt of development finance failing to live up to commitments that they have made to state or national governments to provide a proportion of their healthcare free of charge to people living in poverty. And they've made those promises in return for free or subsidized land provided by the government or other forms of tax breaks. Again, this is then public money that is being wasted, giving these gifts of free land or tax breaks that could otherwise have been invested in strengthening public provision of healthcare. The next principle, be driven by patient-centered needs and social accountability for health rather than commercial interests. And I'm afraid that the private healthcare actors funded by the DFIs are driven first and foremost by commercial interests. But I also think it's concerning that we see these commercial interests driving the rhetoric of the development actors themselves. For example, we all know that there's a globally agreed goal by all governments to drive down out-of-pocket expenditure on health. We know that this out-of-pocket expenditure is a major cause of financial hardship and pushes millions into poverty, hence why we're trying to bring that down. But rather than seek to tackle this problem of huge and damaging levels of out-of-pocket spending, development institutions see it as something their investee companies can capitalize upon. So they actually say this in their rhetoric, that the evidence of large-scale out-of-pocket payments is evidence that these businesses can thrive. There is also evidence that these same companies further drive up out-of-pocket payments by inflating bills and in some cases charging illegal payments. We also know that business models for these companies rely on people needing curative care. This is where the most profitable part of their businesses are. Cardiac illnesses are a leading cause of poor health outcomes in India, for example. And the UK government funds corporate hospital chains focused on so-called affordable heart surgery. But these same companies have zero incentives to provide preventative care or to tackle the wider root causes of such high numbers in need of treatment. And we've also seen these companies acting against patient-centered needs, with hospitals tricking or intimidating patients into having unnecessary procedures and tests. One example, a WhatsApp leak about one DFI-funded hospital in Kenya showed the extreme pressure that health workers were under to increase the number of admissions, regardless of need, in order to meet commercial targets. And in India, we're aware of the horrific scandal of private health companies persuading thousands of young women to have unnecessary hysterectomies for conditions including, fairly straightforward period pains. They do so because the public health insurance scheme makes this a profitable procedure, not because it's in the interests or needs of the patient. The next principle, to have a demonstrated public health impact, be evidence-based and adhere to the principles of equitable access to services. And I would say from our research, the DFIs perform woefully on this principle. Evidence of public health impact is thin or usually non-existent. on the whole, the evidence to justify the private healthcare investments or to measure their impact is criminally absent. Even in the case of the UK's DFI, which has invested in the development of a health impact framework, the results of its application are deemed commercially sensitive, so they simply won't share. All we get for each direct investment is a sentence or two at best explaining anticipated impact. And nor do they provide any evidence of known potential risks or harm to patients or to equitable access. Many of the known and evidence risks of financing private sector involvement in the delivery of healthcare go completely unacknowledged by the DFIs. And of course, this is a failure of the DFIs, but also, of course, to the governments who fund them, who fail to enforce any meaningful rules on impact. And again, the DFIs fall down on the next principle of having strong transparency and accountability mechanisms in place, in line with the principles of aid effectiveness. In short, for us, even identifying where the money is going has been a very long, arduous and painful task, taking months and months of research and investigations. And even then, we know that we don't have a complete picture of all the health sector beneficiaries of DFI finance. The problem is particularly bad because of the high use of financial intermediaries or equity funds. So this is where the DFIs invest in a fund, and then that fund goes on to invest in the health companies. And with the exception of the UK's DFI, those ultimate recipients of investments from the equity fund are not published, are not declared. So you know, in cases we've had to Google and search the funds ourselves. In cases we simply cannot trace where that money is going. We've also found that the ownership structures and tax practices of these companies are very opaque, with most of the equity funds themselves domiciled in tax havens, along with some of the health companies themselves. And consequently, I think it's safe for us to conclude that in cases, even the DFIs themselves are not entirely clear where all their money is going. Or at least we can definitely say they are not bothering to track it closely, let alone report it. And as for those aid effectiveness principles around consultation, ownership and accountability in the countries where these investments are taking place, it's equally non-existent. In our research with stakeholders in India, for example, we found parliamentarians and local government officials weren't aware of these investments at all, let alone the local communities and patients where these private sector companies are operating. The next principle about supporting and promoting human rights and workers' rights and the rights of women and girls and other marginalized groups. So here, not only have we identified human and workers' rights abuses by the healthcare providers benefiting from DFI investments, the details of which we will save for our publication, we note the absence of any sufficient safeguards in place in the DFIs themselves to prevent these abuses happening. Some of these abuses are actually quite well known and in the public domain, yet the DFIs seem to either not have noticed them or are choosing to ignore them. And the environmental and social safeguards that are in place are either not applied comprehensively enough or are also ill-suited for the multitude of complex ways in which the power inequality between healthcare providers and patients plays out in reality, and in a way that can cause extreme harm to those without power. And finally, on the last principle, and very related to the previous point, not to promote private sector investment in health in countries where there is not effective regulation of the private health sector. So I would question which country does have effective regulation of the private healthcare sector, and would welcome people pointing to those examples. What we do see are DFIs investing and at scale in countries with entirely inadequate regulation in place to prevent abuse, exploitation, and other forms of harm. This means that DFIs are promoting the growth of an industry that is known for its ability to perpetrate harm and inequity without any meaningful measures in place to prevent this happening. It's dangerous and should be enormous cause for concern. So I'll conclude by urging you to keep an eye out for Oxfam's publication on this in 2023, but to also really warmly welcome the launch of these principles by STOPAIDS today. The role of the private sector in healthcare is contested for very good evidence-based reasons. We are all aware of the disaster zone that is the US healthcare system. Privatization, commercialization, and financialization of health are fought against in countries around the world for driving up inequity, undermining the right to health, and putting profits before public health. And it's time for the global health community to get more organized in holding development actors to account for what we see as a very dangerous trend in financing an ever greater role for the for-profit private actors in both the financing and delivery of healthcare. Thank you ever so much.
Thank you so much, Anna, for that really thorough insightful presentation. Delighted that you're able to join some of the excellent further research being done by Oxfam, and really pleased and excited to read the paper coming out soon as well. I'd now like to turn to a penultimate presentation from Mohga, who is joining us as an advisor as the People's Vaccine Alliance, but also a long-term access to medicines advocate and campaigner as well. Mohga will be sharing some reflections on the use of ODA funding on biomedical research and development, and considerations on the principles as well too. But over to you, Mohga.
Hello, thank you for inviting me. I'm so delighted that the issue of the dangers of privatization of healthcare is still on the agenda of civil society, despite COVID, you know, that kind of delayed a lot of things COVID did. So very glad to be with you, and very delighted to see the principles that STOPAIDS has put forward. So I'm not going to take each principle separately, but just collectively, I want to make a few points. So the first point is that what we learned from COVID is actually what COVID illustrated clearly is something that activists in access to medicine have known for decades and decades, which is that the importance or the essential role of public funding in research and development for medicines. And when I say medicine, I mean medicines, medicines, vaccines, diagnostics, PPE, basically medical technologies, and how public investment in these products have been absolutely critical. Without it, we wouldn't have had anything that we already have now. So that spin over from basic research in universities where, you know, scientists are researching something that nobody knows what it will lead to actually research for a specific disease target, research for a specific medicine, and then the production of that medicine. So that role is normally not really well illustrated, certainly not by pharmaceutical companies who gain the profit, but even by governments, you know, try to find how much the UK, for example, has spent on research and development in general, or in a particular medicine, or for a particular vaccine. It's so difficult to find the information. So it's even governments are not interested, it seems, to define what they spend on research and development. So what happens is when you spend on research and development, you spend on risky business. So like, as you know, scientists are investigating, I don't know, a particular protein. It might reach something at the end. If you spend the money, you might reach a conclusion that is helpful for developing a drug, or you might not. So that risk is taken by the public. Now, when the research, let's say that protein, you know, is identified as a target, and therefore there is that medicine to treat that particular disease, then the profit is privatized. So basically, we, the public, spend the money or most of the money anyway. The private, of course, spend some money on developing the medicines, but then they privatize the whole profit. And because the whole issue of medicine, the whole medicine chain from R&D until it reaches the patient's mouth is all secret. There's just it's shrouded in secrecy. That transparency is a dream for us. So because of that, you know, you don't know how much the company spend, how much, we don't know how much the public spend. In most cases, sometimes we find out. And then the company can come and say, well, you know, providing that medicine for non-profit. Well, how do we know that it's non-profit? You just don't know. What is in the cost, in that package called the cost of production? What's in it? You know, the actual cost of the material, or the cost of the scientist, all the admin, all the cost of the bonus for the CEO. You just don't know. So all the principle of transparency is out. And therefore the principle of accountability is out. You know, how do we hold a company accountable when we don't know what the ins and outs of the deals? And unfortunately, this is not a commercial failure. This is a public policy failure, because it is governments that are allowing that. So what we saw in COVID, governments have been pouring money on companies, on research institutions, fair enough, and on companies with no conditionalities. So there's no conditionality even on price. So, like, you know, the UK paid the money for the price of the medicines, or the money that they put at the beginning of the vaccines, or the money they put at the beginning for what's called advanced purchasing commitment, with no even conditionality that you give me this at X price, even for the UK, let alone for other countries. No conditionality on sharing technology, no conditionality on intellectual property, absolutely nothing. You know, we will give you the money as a public, and you make the profit you like and sell it wherever you like at any price you like. And of course, that is, you know, it's irresponsible, it's immoral, and it's inefficient. That also happens with HIV before, it's happening with cancer medicine, it's happening all over the place. It's just COVID has made this quite clear. So in a document that the People's Vaccine Alliance have put forward for the currently negotiated treaty for pandemics, we put 7 principles that, or 7 actions basically, that the treaty should include, with practical measures under each principle, under each measure, to ensure that what happened with COVID, and before that what happened with Ebola, with HIV, you know, doesn't happen again. So that includes that all governments' purchase should have conditions on sharing technology and sharing intellectual property, that there should be investment in building manufacturing capacity in the South, and therefore there's no problem, the current problem of supply and of high price that shouldn't be there. You have more companies producing, therefore you have more supply, and the more companies you have, to a certain level, the more companies you have, the more competition you have, and the more the price comes down. So you figure you win on supply, and you win on availability basically, and you win on affordability. But that doesn't just apply to rich countries should invest. It also applies to our countries. You know, developing countries should prioritize medical research and should invest in health in general, but also in medical research, so we don't repeat the same problem. The same problem is repeated with monkeypox. You know, it's just amazing how monkeypox was discovered in 1970. Monkeypox has 2 variants, one in DRC in Africa, and that's the one with high fatality. The one in West Africa, which is the one we have in Europe, is the one with low fatality. And what happens, suddenly everybody's talking about monkeypox. Suddenly we talk about vaccine, suddenly we talk about medicine. Oh, we do have a vaccine. It's developed for smallpox, but it's also approved for monkeypox, but not for Africa where it's actually killing people. We're again, same problem with COVID, relying on, in this case, in monkeypox case, relying on one company to produce vaccine, one company to produce medicine. They dictate the price, of course, and rich countries, the UK, the US particularly, but the UK and Europe have guaranteed supply for themselves. And to be honest, because it's only one company, there isn't even enough supply for these countries. And of course, there's not one single vaccine that's reached Africa. So in terms of public health principles, the way research and development is funded with no conditionality whatsoever means that we have this huge inequality, and therefore we have a negative public health impact. In fact, we do have a public health impact. It's just negative public health impact. And as I said, no transparency and no accountability. Now, the other side of investment is pharmaceutical companies trying to protect their profit. And because, the civil society like yourselves and all of us, because of the campaigns we do, the companies like to clean their act. So particularly on the HIV story, some companies started to give donations and do projects in Africa. And these projects are normally promoting private sector for delivering healthcare, nothing to do with medicine, but for delivering healthcare. And again, it's company X deciding to train some doctors, or company Y deciding to work with a particular healthcare delivery company. You don't know anything about the deal, who's providing what, for how long, where do you get the workers, as Anna Maria said, where do they get these workers, what rights they have, what kind of stuff. So we're just doing it as a charity, and that's it, you just accept our charity and be happy with it. Don't ask us, why we're doing this charity, and the fact that it's done for commercial reasons is out of the story. Now, there is another way of doing these things, and particularly for ODA. So for the British government, I don't know what it's happening right now, to be honest, but over the past few years, the ODA, a part of the ODA was going to support some initiatives for research and development that were to produce to produce medicines that don't exist for what's called neglected diseases, and to produce them in a way that they become available and affordable. So the ODA, public funding is funding the Drug for Neglected Disease initiative, which does exactly that. They just announced today that they produce a medicine for leishmaniasis, one of these very bad diseases that exists in Africa and Asia. So that's a good way of investing public money. Now, the Drug for Neglected Disease is totally transparent. It works with the South. It works with companies in the South, does clinical trials in the South. Everything is open, they're open to public scrutiny. So they provide a different example of using public money to produce public benefit in terms of public health. So that's one good example of how the money should be used. The other thing is, again, in the old days, the UK used to privilege, I would say, when they would give grants to research institutions in the UK, they privilege the one that have collaborative work with universities in the South. So that in that way they were enhancing the capacity of researchers in the South, without just going there, the government itself going there and doing whatever they want to do. It's a particular research that's agreed by both the UK university and, say, the University of Makerere or other universities in the South, and the research gets funded for both. And there is this exchange of knowledge, exchange of information, development together. And I don't really know why this is not a model that should be promoted and where the public money should be spent. Yeah, I'll stop here, and hoping that we can discuss further how public money can be spent to promote public health in terms of research and development for medicines that can benefit everybody, not just those who can pay. Thank you.
Thank you so much, Mohga, for that really insightful presentation. Of course, as you were reflecting, a key deliverable, we think, in terms of the recommendations and taking us forward is looking at the public funding of R&D. So it's brilliant that you're able to share the history, but also the current challenges we're facing now, including the negotiations over the pandemic accord and the different way of doing things further. Now we've, of course, had some really powerful, insightful perspectives and presentations from civil society organizations, some of whom were involved in the development and drafting of the principles. But I would now like to turn to John Fairhurst, Head of Private Sector Engagement at the Global Fund. Of course, the Global Fund being one of the largest health multilateral organizations, and a partnership model with the as partnerships with the private sector and programs as well, team. Really keen and delighted that you're able to join us for this call, John, and really interested for your perspectives on the principles and also Global Fund's engagement and learnings on working with the private sector, particularly in relation to your next strategy as well, team. Over to you, John.
Yeah, thank you, James, and yeah, thank you for the invitation. And I know we're already past time, so there's been a huge amount in Mohga and Denis and Anna's input, so maybe I'll be relatively brief. So, you know, I think this is such an important conversation, and you know, the principles I think are really crucial, you know, even more so at the current time. Obviously, coming sort of off the back of our replenishment, but sort of recognizing the context that I think Anna sort of referred to too, where, you know, we know across the world there are, you know, incredible challenges to economies, to people, and their lives, and you know, the context of, we see in the cost of living crisis, the, you know, the impact of high levels of debt in countries, as we know, will land very squarely on the, you know, the poorest and the most marginalized. And so what, you know, what I think it means is, you know, we have to find a way to sort of optimize our collective impact, and you know, recognizing that, you know, many of the health systems, the countries where we work are already mixed health systems. You know, the private sector plays a role in almost every country where the Global Fund works. I think it's really critical that we're dealing with the negative impacts that people have described. It's crucial that we do that. It's obviously also crucial that we enhance and accelerate the positive impacts of this. So I think that, you know, the framework of how we do that, and the sort of guardrails of the principles are really critical, because it needs to guide how we are investing our funding as well. Now, the Global Fund is a public-private partnership, so accepting all of the challenges that people have put to them, you know, I think there are some examples of where it can work. But of course, what the Global Fund has is 20 years of experience of, if you like, managing a multi-stakeholder mechanism. And I think we know it's not straightforward still. There are many conversations, debates, and conversations we have between our different constituencies. Sometimes they land comfortably and not always. But I think it does speak to this sense of, you know, not just transparency, but the really critical need for dialogue. You know, if we're to move forward, then we have to be able to speak to and engage with the other people acting in this space, and we have to bring them into the sort of principles that are outlined here as well, because that's how we'll drive change. And I think that's our, a key experience, I think, in the Global Fund is about that you have to get into the dialogue. You have to have the uncomfortable conversation around understanding and having the transparency of how people are working in order to resolve this. But I do think that's really critical in terms of how we move forward. In terms of our experience, I think, as some people on this call will know, we actually started a process just at the beginning, unfortunately, of when COVID sort of struck, to develop a sort of framework for engagement, for looking at private sector engagement. And not surprisingly, it has many of the same parameters that you have on the screen here. So, very much centrally around, we need to move away from public-private partnerships as being an end. They are a tool, they're a means in terms of many different models of engaging organizations. And I think, as people on this call have sort of referenced in a way, that there's a danger that that because they seem cool or they sound cool, or they're the trend of the discussion at the moment, that we stop thinking about why, and whether those models are even the right model to solve the problem statements that we see. So being very much, as the principle here says, being very much impact-led, understanding how we make sure impact is the central component of the discussion, and really importantly, maintained as the central component of the discussion as the program moves forward is really central, I think, to driving success. We also had a principle which is, I think, implicit in these, but one of additionality, and that we need to be clear that these mechanisms are adding value, and they're adding value in the sense that they're not just displacing money from one place to do something, but they really are additive to the total consequence, the total impact of what we're trying to drive. And that's really key. They're driven by country ownership, they're driven by engagement with civil society, and not by either commercial or global interest is really important. And then I think that's come out very strongly from the previous speakers, is this sense of transparency being fundamental to not just the setup and the implementation, but this management of keeping impact as the core, that we keep that very central as we go through. And then underpinning that, we have a set of principles, or if you like, operational considerations, which again speak to many of the things here. So things like governance, not just the governance structure, which is principle 6 in the country, but also governance of the initiative, that we're very clear, how the partnership is being governed, and understanding the roles and responsibilities, and again the transparency of this, and the engagement of other stakeholders like civil society in the governance is really central to us. So I won't go through all of the different principles, but just to say that this was a discourse that we created to bring the private sector and our other stakeholders, civil society, the public sector, together to actually create a sort of collective framework, if you like, of how we implement. And I think that is one key thing in terms of how we move forward from these. Is the key is getting the people who we're speaking to engage in them, to accept them, and to build solutions out which are using this as a sort of framework of design and a framework of implementation. And I think that's how we can move forward. So, the Global Fund experience is certainly that sort of public-private partnership can be really powerful because we are one, but very much that it requires the sort of principles that you have outlined here that guide us, but B, this really important dialogue and constant dialogue between the parties to enable to us implement in alignment with the principles is key, and that dialogue requires resourcing and maintaining throughout the life of the initiative. So all that to say, really fantastic conversation. We clearly didn't have enough time to delve into it deeply, so I very much hope we can continue to talk about this. But thanks very much, James.
Thanks so much, John, for your reflections and sharing the work on the Global Fund and the journey you've been on with the strategy and your 20-year history as well. And yeah, absolutely, given the broad range and case studies of the principles, not able to get to all of them for the necessary discussion. And we're really hoping that the launch of the principles and the colleagues that joined the discussion today, in line with John's reflections and the importance of continuing to dialogue, and this will just be the launch pad of this. I know health campaigners will be meeting next week at the Future is Public conference in Chile to map out further vision for anti-commercialization and public ownership and public delivery. And we'd be really keen as well, join civil society campaigners to maintain this dialogue as well. It's pleased to hear that there's some similarities and agreements between Global Fund's work and what we outline in the principles, and it'd be great to maintain this dialogue, particularly moving into implementation of the Global Fund's new strategy and further investments aligned to that as well. But I'd like again to remind colleagues, if you haven't already, you can please do follow this link to download an advanced copy of the principles documents, and there's also a Google form to sign up and add your organization's endorsement if that's something that you would want to consider to do, or would be happy to share with amongst your civil society partners and networks as well. And please do tomorrow watch out for the official launch of the principles, and we'll be sure to share this podcast as well, the recorded version of this podcast, along with the paper as well too, particularly for the colleagues who weren't able to join us live this afternoon in the UK time. So it just leaves me to again to close to say thank you very much for the amazing panelists and everyone who joined, and we're looking forward to working with you all moving forward. So again, a massive thank you to Denis, Anna, Mohga, and John, and for everyone's interventions and questions today. And looking forward to working with you all going forward on the delivery of the principles. Thanks so much.
Thank you.
Thank you, Cole. Thank you. Thank you, everyone.